Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans, and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, we will be discussing enabling heart failure in primary care. How can we assist primary care to be champions of heart failure? A podcast about heart failure, why the simplest ideas often save the most lives. This podcast asks one question over and over again. How do we enable heart failure in primary care, and how can we assist primary care to be champions of heart failure? Because if we don't enable primary care to be champions, we fail. It doesn't matter how efficient the specialists become. This afternoon, we are doing a podcast from the Liverpool Podcast Studios in Liverpool. And today I've got...
Hello there, I'm Claire Taylor. I'm an NHS GP and Professor of General Practice at the University of Birmingham.
Hi everyone, my name is Rajiv Sankanaran. I'm a heart failure cardiologist in Liverpool.
Hi, I'm Fozia Ahmed. I'm also a heart failure cardiologist based in Manchester.
Fantastic. So here's a question for you. Do you think primary care is under-involved in heart failure or under-enabled? So here's a question for one. What feels hardest about managing heart failure outside of secondary care? Let's get a secondary care consultant's opinion on that.
Yeah, I can probably talk all day about this because I do feel quite strongly about some of the terminology, in terms of primary care and how secondary care or tertiary care views the responsibility and the role of primary care. Sometimes it's so primary in terms of it shouldn't be in terms of chronology or relinquishing responsibility. So it should be a shared responsibility between all the clinicians wherever we work in terms of diagnosing and managing people with heart failure. Again, it goes back to how stretched we all are. Primary care is quite stretched. COVID sort of amplified and magnified that. I'm sure Claire can come into it. But throughout the NHS, it feels like you're playing 90 minutes and extra time without enough subs. It's quite difficult. So that's why it's a team-based approach. We should work together. So I, as a hospital clinician, I've felt the value of going out into primary care, collaborating on projects, doing community clinics.
You're very community-focused, aren't you?
I think most people are, but it depends on
But if we looked at your team versus others, it's pretty community, it's secondary care based, but community spread.
Yeah, and whether we go out and do more work in the community or simply support community teams in primary care, it's about opening those relationships, because historically it used to be letters and referrals and us responding to them that way. But it should be more sort of picking up the phone, emails. So breaking down those historical barriers in managing these patients, especially with long-term conditions like heart failure, because it's not a one-off visit or a one-off diagnosis and then you say that's it.
Fozia, what do you think?
I think it's very easy for me to sit in a clinic in the hospital where I've got 20 minutes with a patient and the patients are coming to me because they've got suspected heart failure. So my window of diagnosis is much narrower than when patients present in primary care. They come with breathlessness. There are many possible causes of breathlessness. Is it anemia? Is it COPD? Is it the heart? Is it the lungs? Is it something else? So, and you've got 10 minutes in which to sort that out. It's very easy for me. I've got an echo next door. I've got an ECG. I've got blood tests. Within 20 minutes, I can get a result. So I think it's important that we work collaboratively to find solutions as to how we can remove barriers to access and perhaps enable primary care to reach a diagnosis faster by reducing that time for the patient to pass along the pathway. I don't think it's interesting with the NHS, it's a single payer, single provider service, but we all do things so differently, even within the same city. So it'd be great to actually sit down and figure out what works really well in some areas and then just use that as a blueprint rather than every single area going through the mill and reevaluating and starting from scratch to figure out the pathway.
Replication.
Yeah, and scaling up good practice, getting rid
Isn't
of...
that what guidelines are for then?
Well, guidelines are interesting because guidelines are the minimum set of standards that you should be delivering. They're not really... They're really designed for the generalist. They're not really designed for specialists, because I think that the specialists should be doing that anyway. The problem is that they're implemented with varying degrees of fidelity. So some places stick to the guidelines, do really well. Other places actually evidence-based practice is more difficult to deliver for whatever reason. So I think guidelines are are exactly that. They're a guide, and they're implemented differently in different areas.
So
the reality.
Yeah. So what gets in the way of primary care fully owning heart failure, Claire?
I think it is a challenging environment, and I really like that my two cardiology colleagues see this as a team approach, because it really is. And the main thing is there's this patient in the middle that is moving between all the different teams and along this pathway, and that's the most important focus. So we do need to break down those barriers between primary and secondary care. I mean, as you say, NHS primary care is super busy, just like hospitals are. But in primary care, we see about 90% of all NHS contacts. You know, there's well over 1 million GP consults per day with GPs and their primary care teams. So what we need to be able to recognise and diagnose heart failure earlier is that awareness of heart failure and the key symptoms of heart failure, both within primary care amongst GPs, nurses, pharmacists, so we can identify people who are feeling breathless, exhausted, ankle swelling, and think, could this be heart failure? Time for a simple blood test. But we also do need to go more widely to communities, to patients, to families, so that they also recognise these key symptoms, because unless they come through the door of a GP practice, then we won't be able to identify them and diagnose. I mean, as you've said, there's lots of reasons why somebody can present to primary care with these symptoms like breathlessness or excessive tiredness. And I think that's part of the challenge, and where some of the delay comes from is because it might be a chest infection, we'll treat with antibiotics. Somebody's got COPD, we might optimise their inhalers first. But I think in primary care, we do need to be better at thinking about the possibility of heart failure, particularly if we've tried a treatment and it hasn't worked. And as Nick said, if they're in one of these high-risk groups, so people with type 2 diabetes, people who've had a heart attack, got AF, COPD, high blood pressure, they're more likely to develop heart failure than people who don't have those conditions. So I think we do need to really raise awareness within primary care and the wider communities, and that's what BEAT is all about. So breathless, exhausted, ankle swelling, time for a simple blood test, a natriuretic peptide test, which can be done simply in primary care. And if it's raised, an NT-proBNP above 400, we know what to do. We need an echo and a specialist assessment through our secondary care colleagues.
I think one of the issues we've got is even, when primary care does all the things right, gets the diagnosis, does the NT-proBNP, it's about us making sure that whatever happens thereafter, the need for an echocardiogram, for example, those waits are not prolonged. And we see across the country that a lot of people are waiting for those tests, isn't it? Heart scans, treatments to be initiated. So I think we need to make sure that we bring all the elements of the pathway together. So it's not just about one part of the pathway.
And I think what we're saying is that, as a healthcare community, we can't treat what we've not diagnosed. Breathlessness is not a diagnosis, it's a symptom. There are many possible causes, but using this framework allows us to rule out the more sinister, more serious causes of breathlessness that would come to a cardiologist for review.
Yep.
And just to pick up on the echo weights, that's such a huge issue in primary care. So even if I do an NT-proBNP blood test and refer, I then often have a patient with me for sometimes weeks or months who I need to manage. So I can start diuretics and try and offload them. But I think having that support and perhaps advice and guidance is a way to bring that. I can contact cardiologists directly and say, I've done the diuretics, this patient's still really struggling, because what we want to avoid is that emergency hospital admission, and that happens in far too many patients. Sometimes people are just too sick. They sit in my room and I say, I need you to go to hospital because you need drugs into the vein to get you better quickly. And we need to be getting much earlier in the process to try and intervene sooner to avoid those emergency admissions, which are so frightening.
When we say primary care champion in heart failure, what does that actually mean in practice? What does that mean?
I think it means making it a priority in a way that we've made
But how do we
other
do
diseases.
that? Because we've got lots of specialists, and maybe it's the specialists need to stay quiet, and we always say, we always talk about it, but when's it actually going to happen?
Yeah.
All right, we come to a junction in the conversation
No,
there.
I think, I sometimes think that actually those labels of primary, secondary care allow us to shift responsibility to the other side.
Do you think that's what it is, though?
No, I think I think it happens. It's almost that concept of not my circus, not my problem.
It's a human thing.
That we say, oh, it's primary care, the patients aren't being referred to us or whatever else, instead of actually working as a team. Actually, we're in one area. How can we work better to serve the needs of our population?
I think it's also, sorry, as a specialist, I thought I'll stay quiet, but I have to say something. But I think it's also, to an extent, you mentioned guidelines and pathways and systems. By creating some of these and saying, say, for example, an echocardiogram. Why should a simple ultrasound scan always be performed in a secondary care or a hospital setting? Why can't it be delivered in a community setting where a patient is seen and they have their blood test, which is abnormal? So some of these barriers we have created, and by being very rigid and regimental about these things, we are actually pushing patients away from where the care can be delivered, which is in the community. So it's about taking the care and the treatments out to the community. So like I said, these investigations and treatments, they're not that specialized. A lot of them have been around for decades.
Is that our
really.
problem, though? Because for many years we go, oh yeah, it's really, heart failure is really complex. Well, there are elements of it that are very complex, but there are also elements of it that are very doable by generalists and I wasn't say poorly trained, but an educational level that everybody understands. So the question is, what should sit confidently in primary care and what shouldn't? And for me, as a patient, that's the diagnosis. That's instigating the further tests and investigations and the heart scan echo. And then what happens when the patients get taken out of multidisciplinary team, away from the FOSIs and the Rajives teams, and back into primary care? It's that medicine management. It's that helping them live with it. Am I right in saying that, or am I? Because we then say, well, you don't have to look after all of it, do you?
Yeah, and I think it is a process that moves, and we are the first point of contact in the majority of cases. So beat is absolutely key for us as primary care teams. We need beat awareness. I now write in my notes, no beat symptoms, like I write no fast symptoms for stroke. And I think we need clinicians to be doing that. When patients see our practice nurse for a long-term condition review for their type 2 diabetes, they need to be aware of if the patient does look a bit breathless or their ankles are a bit swollen, actually they need to think and feel enabled to ask them, are you breathless, exhausted, ankle swelling? And if the answer is yes to any of those, they need a mechanism within the practice to request that simple blood test, that natriuretic peptide test, as you would do if you suspected other conditions, whether that's the nurse themselves or talking to the duty doctor and getting the patient seen and the blood test organised. So I think there's lots of ways that practices can become beat aware practices, heart failure aware practices.
Oh, I like that.
Yeah.
Beat aware.
Yeah.
I love the beat symptoms, no beat symptoms, but then actually I'm sat here thinking, do we need to just get this in the curriculum? You know, that's where the common starting point for everyone's medical education, nursing educational, professional education is in the universities, in the colleges and on the courses. And maybe it needs to sit in the curriculum, because these archaic ways of diagnosing patients of breathlessness can be all these causes. It requires you to remember everything. But
I also think it needs to be non-confrontational as well. It needs to be easy without too much friction.
Yeah, and universal. So it's across everyone's learning.
I mean, I heard on the podcast the other day about somebody in primary care saying, well, it's just more work for us to do. But it's a very, very simple acronym, just like FAST. And it doesn't have the immediacy of FAST, but it's an instigator and an opening of that important NT-proBNP test. And certainly as a patient, I would want an NT-proBNP blood test, and then it would instigate either an echo or not, then just go towards an echo.
Yeah, and I think that's a really important point. It's a very simple blood test that primary care have access to pretty much across the country now. But our research, I lead a study called Diagnose MP, which uses large GP data sets to look at what's going on in terms of natriuretic peptide testing. There has been a huge increase since the NICE guideline in 2010, but still our most recent data show only 1 in 4 patients are getting a natriuretic peptide blood test prior to diagnosis. So we need to be testing more. And the only way we can test more is actually having this awareness of the symptoms and then doing the test.
So would you say that in primary care and with GP teams, that is the most important thing at this current point in time, is to get people into those diagnostic pathways so that we can find out whether it is heart failure or not? Because I've always been told that if you're breathless, there's a reason why you're breathless. So we need to find that out.
Absolutely. And you don't want to test across the board. You need patients to have symptoms and to think, could this be heart failure? Do this simple natriuretic peptide blood test. And it's a very effective rule out test. So if NT-pro is less than 400, you can be confident that it's unlikely to be heart failure, but with caveats around that. If patients have obesity or on other medications which can lower the natriuretic peptide test, we do need to take that into account if it's a result near the threshold. But it's a very effective rule out test. If it's above the threshold, then we do need to have an echo and a specialist assessment. But there is just this huge need for symptom recognition and more testing within primary care, looking at the data that we've seen, just to avoid these emergency hospital admissions, because we can, fast for stroke is all about time to call 999, get somebody into hospital to thrombolyse them, get rid of that clot, save their brain. This is the opposite almost. The T is time for test, so that we can test early, diagnose and start treatment early, so prevent that hospitalisation, prevent that rush to A&E, which is terrifying for patients. You know, I sit with really breathless patients and have to convince them to go to hospital because it's a frightening place to go, and often they don't want to. And if we can get them earlier, they won't need to.
I think so. If primary care is the front door of the NHS, what role should it play in heart failure? What role should primary care play in heart failure? So let's just go to the specialist here and say, well, we're all specialists here. We're just slightly different, and we live in different parts of the NHS. Rajiv, what's the smallest change that would unlock the biggest impact in primary care? What key can we give to our colleagues?
I think it goes back to BEAT, application deployment of BEAT as a simple methodology, and we demonstrated that with the Pumping Marvellous campaign across the country, isn't it? Using BEAT, each symptom, breathlessness, exhaustion, ankle swelling, that unlocks the diagnosis a lot earlier. So if we can address the delay in diagnosis at the moment through simple deployment of the BEAT campaign in primary care, I think that will be a quick win.
Yeah, and I'd go to the next step after that. So before we can treat something, we need to diagnose it correctly. So if you've got someone who's got BEAT positive symptoms, the next step is actually, have we got access to timely diagnostics, so an echo, a jelly scan of the heart to rule out or assess the heart muscle structure and function. And I wonder whether the diagnostic hubs will play a role in this. But I do think that there needs to be a transformation in the way that we utilise echocardiography. We can't keep doing the same thing and expect different outcomes. We've got huge waiting lists. So maybe that's a role for AI echo in the future. But I guess my question to both of you is, do you see the diagnostic hubs, these places where these mega diagnostic centres affecting or changing time to diagnosis of heart failure?
Yeah, I think, again, when we do clinics, isn't it, Fawzia, we see people, about 20% of people don't attend clinics.
Mm-hmm. Yeah.
And there's a reason for that. Either they're too unwell, they're struggling to get parking, they don't know where to go to. It goes back to the point about getting these clinics in the community. It doesn't mean that we're taking the specialists out, because you still need the specialist diagnosis. But it's about enabling and supporting people in the community, including primary care, working with them, interpreting that echocardiograms. If they need further testing, like MRI scans, for example, ensuring that the patients still get that. So it's not about moving everything out and stopping there, but it's about moving some of these tests which can be delivered in the community to be done there. So,
but if we got this right, how would that impact the patient, Claire?
Well, I think, just to move on from that point of diagnosis, which is absolutely key to them patients receiving these life-saving therapies, which we know can improve quality of life, they can keep people out of hospital and they can make them live longer. So, it's a very positive thing to be able to offer people all of these treatments, and of course cardiac rehab as well, which is as good as any drug we have. But the diagnosis is the key point. But then primary care has a real role in management. And I was on the NICE guideline committee, which has just updated the management part of the guideline. And it very much enables primary care to work with specialist colleagues to initiate and optimise these treatments, which I think is really, really positive. So I think we do need the pathways and the systems to really recognise that there aren't these artificial barriers between primary and secondary care. Yes, we need the specialists to do the specialist tests, interpret the echo, the cardiac MRI, give that diagnosis because it's a huge diagnosis with huge gravity. But then we need to work together and see who's the best place to optimise these treatments. So it could be a pharmacist working in our practice. It could be some GPs won't have as much experience with sacubitril valsartan, which is now part of the NICE guideline in patients who remain symptomatic. So, perhaps we can send an advice and guidance saying, this patient's eligible. Can you give me some guidance on how I initiate this? Just while we get our confidence in that. SGLT2 inhibitor drugs is something actually primary care is very familiar with, probably more than cardiologists potentially. So we've been using them for years for type 2 diabetes. So actually that's now a guideline recommended therapy across the ejection fraction. So I think they'll hopefully be used very rapidly because primary care are very familiar with those drugs and they would be easy to initiate in primary care. So I think it's a really exciting time. And once you've got that diagnosis, whatever the type of heart failure that you have, there are treatment options now, and that wasn't the case in the previous guideline.
I think that's super important that there are, for the various different types of heart failure, there are now prognostically valuable medications. Whereas only a couple of years ago, 2023, I think it was, we got our first prognostic treatment pill for heart failure with preserved ejection fraction for a population of 500,000 people. And now we've got even more. Hopefully this year in 2026, we will have more opportunities for those people. So just to leave a question for the audience listening to this this discussion, heart failure, if heart failure is a long-term condition, why do we still design care as if primary care is peripheral?